Dr. Thomas Brown is a clinical psychologist who received his Ph.D. from Yale University. He's the director of the Brown Clinic for Attention and Related Disorders in Manhattan Beach, California. He specializes in the assessment and treatment of high IQ children, adolescents, and adults, and is associated with the Keck School of Medicine at the University of Southern California. You may know Dr. Brown. He is the author of numerous scholarly articles, 6 incredibly helpful books on ADHD, as well as the Brown Attention Deficit Disorder Scales for children, adolescents, and adults, which are published by Pearson. His most recent books are Smart But Stuck: Emotions in Teens and Adults with ADHD, 2014, and Outside the Box: Rethinking ADD and ADHD in Children and Adults, a practical guide. His website is brownadhdclinic.com, and we're really pleased to say that Dr. Brown is a member of Attitude's ADHD Medical Review Panel, as well as helpful at CHAD and ADA and other mainstream attention deficit organizations. Dr. Brown, thank you so much for joining us today.
Thanks, Susan. It's a pleasure for me to be here.
As always with Attitudes broadcast, Dr. Brown will present his slides and then take as many questions as time permits. We have been having some glitches today with slides in our testing, and we decided to go ahead with this presentation today. It's possible that you will not see the slides change, but if that's the case, Dr. Brown will proceed with his presentation, and you'll be able to download the slides and see them later when you're ready to. It looks like the slides may be changing. Are they? Does that seem to be working? Yes, it does. That would be great. So before Dr. Brown begins his talk, let me just ask you to complete a brief survey, just to share with all of us what your medication challenges are. And I guess the options are, does the medication doesn't help your symptoms? The medication wears off too early in the day, or the medication has side effects like appetite loss or insomnia or other. So check the poll, tell us what you see. And while you're doing that, let me tell you a little bit more about the webinar console. You can enter your questions anytime in the Ask a Question section. You can download the slides right now by clicking the Download Webinar Slides in the Event Resource tab. And if you have any audio issues, the best thing to do is close any browser, open browsers, and make sure you have a wired internet connection. So with that, let me turn it over to Dr. Brown with hopes that our technical problems will be resolved.
Okay, thanks, Susan. Today, as Susan said, I'm going to be talking a little bit about what I think of as the fine-tuning of stimulant medications for children and adults with ADHD. And I'd like to take a few minutes as we begin just to review the understanding of ADHD that I'm working with, and then we'll talk more specifically about the medicines. Some of you may be familiar with this from what I've written or from previous webinars, but let me go over it for those who may not be. The big change in our understanding about ADHD that's occurred over the past couple of decades, although the word is not fully out to a lot of people yet, is that the old notion of ADHD, which was originally written up in medical literature in 1902 and went on until 1980 at least, was just a problem of behavior and not listening, particularly in little boys. What we now understand about ADHD is that it's not primarily a behavioral problem, although certainly there's some folks with ADHD whose symptoms include behavior difficulties, but is essentially a problem with the unfolding of the development of the brain's management system, its executive functions. And the story is simply that for those with ADHD, these executive functions, which I'll describe in just a moment, don't come online in the usual time frame, and they tend not to work consistently. Often we talk about ADHD as a problem with focus, but I'd like to emphasize that what we mean by focus in this case is not like hold the camera still while I'm taking a picture. It's not that kind of focus. It's more like focusing on the task of driving a car. Because when you say focus on your driving, what you're talking about is not gluing your eyes to the bumper of the car in front of you. You're looking at what they're doing, but you're also checking your side view mirror and your rear view mirror. You're also noticing there's a truck backing out of a driveway. There's some pedestrians running across the street. You're having to ignore some of the things that are going on and then keep in mind what you just saw. Even as you shift your gaze to look forward or to get ready to make a turn, that's a complex task, focusing on the driving. You utilize short-term working memory. You're utilizing the ability to ignore some things and focus on others, and then call back in mind what you just saw when you looked at the mirror and so forth. It's that kind of focusing, like focusing on your driving, that's a problem for most people with ADHD. Now, the main point here is that the problems that we list as the symptoms of ADHD really overlap with executive functions. They're not such separate things as some of the literature would make you think. That these executive functions include a wide range of control processes in the brain that help to connect and to prioritize and to integrate our cognitive functions for us moment by moment. And the metaphor I usually use for thinking about this is that if you picture a symphony orchestra where all the musicians are really good at playing their instruments, regardless of how good they may be, if you don't have a good conductor, you're not going to get very good music out of a symphony. The conductor has to select what they're going to play, has to get each individual musician to play his or her specific part in the same piece at the same time. He has to keep them on time, bring in the strings, fade out the strings, and keep them all together, working together as a team. And with that, you can get good music. Without it, you don't. And what's happening in the brain are these executive functions is that these are not tied to what would be comparable to the individual musicians. Rather, they're networks within the brain, neural networks that function as the conductors of the brain symphony. Now, just a few more slides to talk a little bit about what's involved in this. The first thing that needs to be recognized about ADHD is that all of the symptoms that we talk about as characteristics of ADHD are things that everybody has trouble with sometimes. It's just that people with ADD have a lot more trouble with it than most others of the same age. So in that sense, ADD is not an all or nothing deal like pregnancy, where either you are pregnant or you're not pregnant. There's nothing in between. It's more like depression, where everybody gets bummed out once in a while. But just because somebody's unhappy for a couple of days does not mean we're going to diagnose them as clinically depressed. It's only when the depressive symptoms are persistent and making a lot of trouble for them, we say, yep, that's a depression. We got to do something about it. More complicated and harder to understand for many people is the second bullet on this slide, and that is the situational variability of the symptoms. And what that refers to is a simple fact, and that is every person, at least every person I've ever seen with ADHD, has a few things they can do where they have no trouble paying attention and exercising these executive functions, even though on almost every other task they take on, they've got a lot of trouble with it. Now, it might be that they're really good at focusing when they're playing a sport like soccer or baseball or football. Or it may be that they focus not well on sports, but on playing video games or on making art or in playing music, or in doing Lego constructions. Different things for different people. But the fact is that everybody who has ADD has a few things that they're going to be able to focus on quite well, even though they have a lot of difficulties in focusing on most other things. And that the effect of that is, it's like the bottom line of this slide. ADHD looks like it's a problem with willpower. You can do it here. Why the hell can't you do it there? When in fact, it's not a willpower problem. It's a problem with the dynamics of the chemistry of the brain. Now, this model, I've written about it quite a bit and talked about it quite a bit. I'm not going to take time to go over all of it now, but just to say that this is a way. There are other models for thinking about ADHD too, but it's a way of conceptualizing, of thinking about what are the real components of ADHD. And you can see on the bottom list these one-word titles: action, and being able to activate and be able to focus, and being able to sustain alertness and effort, and managing emotions, which is not included in the DSM criteria. but it ought to be. Most of us who do research in it feel that's an important omission. Short-term working memory, not long-term storage memory, it's short-term working memory. And then action, being able to control one's behavior, speed up when you need to speed up, slow down when you need to slow down, and take account of what's going to happen if I say or do this. And then you can see above the elaboration on it, and there's a lot of information available about this model if you're interested in getting more of it. Some of it's been in Attitude magazine, some of it's online, and some of it's on my website. But what I'd like to turn to now is this notion that ADHD is fundamentally a problem with the brain's chemistry, and that the most effective treatment we have for ADHD that's scientifically supported is to change the chemistry that's problematic with medication. And unless that problematic chemistry is changed, it usually turns out to be the case that a lot of other things that we might do to try to be helpful are not going to be as effective as they would be if the body's brain chemistry has been adjusted. Now, the fact is, as I'll say in more detail shortly, the medicines that we use for ADHD are effective for about 8 out of 10 people who have ADHD. And what makes a big difference is whether or not that medicine is adequately fine-tuned. Now, this is an old study. There have been a bunch more studies since then, but I wanted to bring this out because it was published in the American Medical Association way back in 1998, and we've got a lot more studies since, but at that time, they were talking about how there were over 170 studies that involved a total of over 6,000 kids using stimulant medicines for ADHD, and up to 90% will respond to at least one of the stimulants, and we'll talk about the variety of stimulants in a few minutes, without any significant major adverse events. If, catch this phrase, this is important, if the drug titration, which just means adjustment, is done carefully. And then the other statement that the AMA made on the basis of that large body of research is that the adverse effects from stimulants are generally mild, short-lived. They don't last a long time. They're usually transient. And they're often responsive to dosing and timing adjustments. In other words, there are things we can do usually to adjust the dose so that it's going to be more effective and reduce the likelihood of its making trouble. And that's the kind of stuff that we're going to be talking about as our main focus today. Now, before going to that, let me take just a couple of minutes for those of you who may not have this information currently in mind about how the brain works, because the medication here has to do with how the brain operates. If you picture the size of the average person's brain as, it's a pretty small organ, has in it 100 billion neurons. These are tiny, tiny cells that you need a powerful microscope to be able to see, but it's an amazingly complex and impressive system. And each one of these little neurons, they have different sizes and shapes, but they all work on a branches and twigs system, interacting with thousands of others in complex subsystems that get organized and that keep changing. It's not like they're locked in systems like the power grid. This is something that's much more complex and dynamic. And they have to be able to talk to each other and shift arrangements. And how do they work? With low voltage electrical impulses. And those electrical impulses have to jump across gaps. And they do it so fast that in 1,000th of a second, you can get 12 messages across. Pretty impressive stuff. Now, this often you see, and you will see as we go on, diagrams where you look in just a couple of neurons at a time. But this is just one slide to say, hey, look, these things are a tightly knit network. And then the connections in the network keep changing. But it looks like a jungle of this latticed connection between them. It's complicated. And that's the area we're trying to do. Now what we're doing is pulling out of that picture of the interlocking connections to say, well, here's what one neuron looks like. They're different sizes and shapes, but you've got all these branches out there which basically are collecting information. And then you have here the connecting point between the sending neuron and the receiving, the neuron that's receiving the signal. And then that little gap that you see in between, that is what's called the synapse. And it's across that gap that the things that we're going to be talking about here have to take place. So let's take a look and see how it goes. In order to make the connections across those gaps, they're small, but they're important because the charge cannot leave from one side to the other without these chemicals. And there are more than 50 different chemicals that are actually made in the brain. These are not chemicals we're putting in there. These are chemicals that are manufactured in the brain. And every neuron system uses one of them. Now, the two that are most important in ADHD, it appears, are dopamine and norepinephrine. But these are manufactured and stored in these little tiny bubbles near the tip of each neuron, right near the synapse, so that when that electrical impulse comes across, and you'll see a graphic for that in just a minute, they're little tiny mini drops of the chemical that get released. And they cross the gap, and that's what facilitates the cross of this low voltage electrical impulse that's going to fire that next neuron, and it moves on to the next one, and they can reload in fractions of a second. Now, that's a description of the process. Let's take a look at how it looks in the diagram. So here we've got the sending side, and these are little vesicles, little bubbles in which these chemicals are manufactured. And then there's going to be an electrical impulse that comes down along this neuron. And when it comes down, it causes the release of microdots of the chemical. And you can see those little red dots are supposed to represent. And then on the sending side, you can see that we've got these receptors that are waiting to catch the signal. And in order to be able to get that signal to go through, you need to hit a lot of the receptors, and you need to hit them fast. And there's nothing voluntary about this. It's all going on automatically. Then if the electrical impulse that came through causes the release, as it should, of the transmitter chemicals, and it hits these receptors. Now, keep in mind that you're looking here at 5 receptors. The fact is there are hundreds and hundreds of them on each one of these. They're really tiny. But if it hits enough of them fast enough, then that message goes zipping along to get to wherever else it's got to go in the brain. But then there's something else that happens, and you'll see a little more of that in a subsequent slide. But basically, there's a process of little protein cells that sit on the sending side, and they are called transporters. And what they do is they work like little vacuum cleaners that just sort of suck it up and pull back what's been released in that transmitter, and so it's reloaded. Otherwise, the system would be locked open and you never get anything else done. And so you can see they're representing here in this cartoon that you've got it back in the packages and where it was made, and we'll be ready for the next message, which could come through in fractions of a second or not for a long time. Now, this is a different cartoon that shows you from a little different perspective the same process I was just talking about. On the top here, you can see that this is the sending side, and you've got this little plastic-looking bubble, and the star things are supposed to represent the little micro dots of the chemical that are being released, and then these little blue things that look like torpedoes embedded in the receiving side, those are the receptors. And so you get the release, it has to hit the receptors. If it hits enough of them, it's going to move on. And then these, reddish colored objects are supposed to represent the transporters, little vacuum cleaners. And what they do then is just suck up in order to be able to get it back in and to clear the system so it's ready to move on. It's an amazing process, and it works so fast. And now the 2 chemicals I've mentioned that are particularly important in ADHD, because there are more than 50 different types going on and moving muscles and doing all kinds of other activities of the body. But these are the 2 that control most of those functions that get impaired in ADHD. And the brain of a person with ADHD makes these chemicals the same way everybody else's brain does. But the thing is, it typically does not release and reload effectively And so some of the control messages often are just not connecting. And that's where the problem comes. But for about 8 out of 10 people who have ADHD, sometimes better than that, depending on which studies you look at, the medications improve this problem. So how does it work? Well, the fact is, this estimate here is between 70 and 90%. Depends on which cases you're looking at. And it's pretty much the same numbers whether we're talking about little kids, teenagers, or adults. However, it's important to say that even though it makes a difference in each of these people, the amount of symptom improvement varies. For some people, it's huge how much these medicines help. For others, it's substantial, but it's not huge. Others, it helps a little, but not that much. And 2 out of 10, it doesn't do a damn thing. But it is important to say, as that AMA report that we looked at a few minutes ago said, is that usually the adverse effects, the stuff that's not supposed to happen, when it happens, it usually is transient. It doesn't last long, and it doesn't usually make that much trouble. We'll talk about the exceptions in a few minutes. Now, this is just another part of that same article that I talked about before, and I'm reminding you that there have been a lot of studies. It's now well over 200 and over 8,000 or 10,000 kids, and we've got more and more studies on adolescents and adults now. Okay, a few things that I think are important to say about the medicines. I'm talking about stimulant medicines for ADHD. Those are the ones we use most often because we've had them the longest, and the research indicates that they tend to work the best for most, although not for everybody. But they have been demonstrated to be safe and effective. Nobody can ever guarantee you that any new medicine that's new to you is going to work effectively. And it might, yes, any medicine can cause some side effects. However, these medications have been around for a long, the ones we use as stimulants have been around a long time. Methylphenidate's been around since 1956. And the amphetamines have been around since 1937. And I can tell you there are more research studies done on these two types of medicine than on any other medicine you or your kids or anybody else will ever take. And the reason is there's this a large, huge body of research on it. And the reason is we use them with kids. There's a lot of solid research. Now, one important fact that I think is very important to mention that often does not get covered very much in medical training is that stimulants are different in some ways in terms of how you go about prescribing them. There are many medicines that a physician can prescribe on the basis of how much you weigh or how old you are or how severe your symptoms are. And one of the common formulas is so many mgs per kg, which simply means milligrams per kilo of weight. But the fact is that unlike the way that other medications are responded to by people who have ADHD, these medicines for treating ADHD, the effective dose is not really based consistently on how old you are or how much you weigh or how severe the symptoms are. It's a matter of how sensitive is your body to this particular type of medicine. And sometimes it's within categories like the methylphenidates or the amphetamines, and sometimes it's even this very specific brand of medicine or the difference between a brand and a generic. But what it means is we need to do very careful titration, which simply means adjusting up and down the dose and monitoring and watch it to fine-tune in order to fit the individual sensitivity and also to adjust for time frames depending on when the person needs the help of the medicine and what tasks they have to do and when they don't, when they need to be off it. Now, one of the concerns that many people have, many parents have, when you start to talk about possibility of having their kids take medicine for ADHD is they worry about substance abuse. I've talked with many parents who have said, you know, we had somebody, my brother or one of his uncles or aunts had a lot of trouble with drugs for a while and were addicted. We saw problems with people who were addicted with alcohol or people who were addicted to pills or people who were addicted to weed or something like that. And I don't want my kid to take any medicine which is going to increase the likelihood that he may be he or she might be more likely to get addicted to something else later. But the fact is, the risk is the other direction. We've got pretty good evidence that shows that if you look at a child who's, say, 10 years old, carefully diagnosed with ADHD, that kid has double the risk of having a problem with drug or alcohol abuse or misuse, double the likelihood of somebody who does not have ADHD, unless they are treated with medication and the stimulant medications that we're using. And the fact is that, so it's not saying that every kid with ADHD is going to turn into a drug addict. That is not the point. The point here is very simple. It's saying that we've got good evidence that shows if you have ADHD, incidentally, I often refer back and forth to ADD, ADHD. I'm using both terms to mean the same thing. But if you've got the ADHD, you're in a higher risk group for that. Why? Because one of the reasons is that the people who have untreated ADHD often have a lot of frustration. They feel like they're banging their heads up against a brick wall, or like they're trying to run a marathon race with a knapsack of bricks on their back. And often their ability to function in school drops off as time goes on, and they end up hanging out with the kids who are least motivated to do school, and that's where you get the highest rate of substance use disorder. But the fact is, substance use disorders for those with ADHD are twice as likely to occur if they're not treated, and they start earlier, they tend to last longer, and it's harder to get rid of them. But the risk of substance use disorder is reduced. Some of the studies don't go as high as the 84% from this earlier study, but we usually figure that if a kid has ADHD and they're treated with medicine, that reduces the risk back to the point where it would be if they didn't have ADHD. Now, it doesn't guarantee that they're not going to have a problem with drugs, just like not having medicine does not mean for sure that you're going to have, if you have ADHD, that you're going to for sure have a substance use problem. But you're in a better situation, lower risk group, if you have a kid who has ADHD and they are treated effectively with medication than if they're not. And that applies during childhood and adolescence. Now, a lot of the worries that many parents have about it, for example, I'm just going to put all these on the list and I'll run through them one at a time. It's important to know. A lot of parents worry, is my kid going to turn into a zombie if they get it? If somebody is turning into a zombie, but which usually people mean a sort of blunting of emotions, they sort of lose their sparkle, they lose their personality. Now, remember that if this happens, it only happens during that part of the day when the medicine's active. What you take today is gone tomorrow with stimulants. And so it's a matter of not permanent personality change by any means, but it does mean that if the person is having that reaction, it can affect them during the time the medicine's active, and then it'll go away when the medicine wears off. But that zombie thing is just a way of describing a situation where you sort of lose your sparkle, you don't have as much spontaneity, you don't have as much sense of humor, you may not feel much like talking to people. And all of these would be different from the way that this particular individual usually is. And the point is, if that's happening, we definitely would say that that is the wrong dose for that person to be on, or it may be the wrong medicine. But you ought to be able to be your regular self when you're on it. The other thing is, some people said, "Oh, is it going to slow his growth, or is it going to start motor tics? So like blinking the eyes, or oral tics, or something like that." There's good evidence that the ultimate growth for people on medicine doesn't vary from the patterns you'd expect for anybody else of that age. Some are a little bit slower to hit their full growth, but it still happens within the time frame you'd expect. Appetite loss, often when you're first starting, the person will lose their appetite. Usually it's just a matter of they don't feel much like eating lunch if you take it in the morning. And it can be a problem if it's continuing. Motor tics happen to a small person. About 15% of kids have motor tics anyhow, and usually they go away on their own. But if that happens, we can usually fix it by changing the medicine. The appetite problems often is a problem for the first few weeks. Usually that gets better. If you take it too close to bedtime, it can keep you up. but the answer to that is don't take it too close to bedtime. And then I've just spoken about the risk of later drug or alcohol problems. And depending on meds for a lifetime, people often say, well, how long is a person going to have to stay on this medicine? And my answer to that is, I don't know. There's some people who are able to get along quite well being on the medicine for just a matter of 6 months or a year. More often, if it's working, it may be something that's going to be needed pretty much for at least a year or two in school and maybe throughout school. And then for some adults, it needs to persist for other things they need to do beyond school. Will it cause my kid to be labeled to have a diagnosis of ADHD, or will people be assuming things about them? Well, that's a risk, but the fact is you've also got to weigh it against the risk of being labeled lazy or not caring about things in school and so forth. Reactions of family, teachers, and peers, usually it's not that big a deal, but there's some families where you'll get a lot of conflict about this, and you just need to educate people a little better. Now, often people want to think about what are the alternatives for this sort of thing. And if you change the diet, or if you feed some supplements, or if you give them optometric vision training or neurofeedback, the fact is there is no good scientific evidence for the effectiveness of these treatments for ADHD. Now, often people say, well, there are two main classes of medicine. I'll talk about them in a minute, but the two classes are generally dextroamphetamine, or amphetamines generally, methylphenidate. The methylphenidate would be the Ritalin-type medicines, and dextroamphetamine would be like the Adderall or Vyvanse-type medicines. In this particular study, who do they have with these people? Who do they have the best response with? About 38% could do equally well in either one. And then there's 26% that do significantly better on methylphenidate, and about 36% that do a little better on amphetamines. Usually younger kids do better for starters on methylphenidate. It's a little milder. And adults and adolescents usually do a little better with the amphetamines, but there's some where it makes no difference, and there's some where one clearly works and the other one doesn't, but they don't come with labels on their forehead. Now, there are various delivery systems for these medicines, too. Like, for example, we're talking, the two big categories are methylphenidate and amphetamines, and we'll talk about both of them in a minute. This is just talking about delivery systems. They're short-acting methylphenidate, and we usually say the average duration of action for that's about 4 hours, but it's 4 hours plus or minus 2. For some people, they burn through it in 2 or 3 hours. Others, it'll last 6. You've got a medicine like Concerta, which has these 3 different stages in it. They say it lasts 10 or 12 hours, but for some people, it doesn't even get you through the full school day. Metadate, the CD version, is 2 phases. They advertise for 8 hours. But for some people, they get more than 8 hours. For other people, it's much more like 5 or 6. Focalin, which is just it basically Ritalin with one of the isomers removed from it. That's about 4 hours. But the other thing that's important to know is Focalin packs double the punch that Ritalin does, milligram per milligram, which is something you've got to take into account. And then the XR version of Focalin lasts about 8 hours. Ritalin long-acting, it's 2-phase things, 6 or 8. But keep in mind, all of these estimates of time, of duration of action vary enormously from one person to another. And the other thing that varies is that how long it takes to kick in. For example, Concerta takes a good hour to an hour and a half for many people to kick in, whereas the short-acting, it's more likely to kick in within a half an hour or so. Depends on a person's body chemistry. Some are quicker to respond. Now, the amphetamines, the dexedrine, it's about 4 to 6 hours. It lasts a little bit longer usually than the methylphenidates. The mixture of dextro and levoamphetamine, which is Adderall, immediate release, 4 to 6 hours. But again, it's plus or minus 2 on each end of this. The extended release, it's important to know one other thing about extended release. For example, in the Adderall XR, if it says, say it's a 10 milligram dose, you're not getting 10 milligrams throughout the duration of that medicine. You're getting half of the dose and then half of the dose. It's like 5 milligrams followed by another 5 milligrams all in one capsule. Vyvanse, 10 to 12 hours. But again, there's some people that can just barely get them through a school day, and there are others where it will operate in a way that goes well beyond 12 hours. Mideas is a 3-phase, similar very much to Adderall, which releases over a much longer period of time. It's 3 phases. But the fact is, how long it takes to kick in and how long it lasts vary a lot from one person to another. That's the reason for the fine-tuning. Now, there's some of these medicines. This is Metadate, which is one of them where they've got these little beads inside. A third of them have a coating on them that releases pretty quickly, and then 70% of them have a thicker coating, and that releases later. That's how you get the time release. And there's several other versions of these things that happen. Concerta, it has a 3-phase thing. It releases a little bit off the coating, and then inside there are a couple of different concentrations of the methylphenidate, and then the polymer substance, which when you get it inside the gut, it absorbs water, and that expands, and it pushes the medicine out this little tiny laser-drilled hole. We've got a patch version of methylphenidate called Datrana, where you just put it on your thigh, and it's like a big Band-Aid, and it'll carry a person through about 9 hours. Adderall comes in these short-acting tablets, and they dump everything they've got initially. Then the XR version, these are the ones where I say divide the face value by 2, and you'll know how much is being released at a time. But again, how long it lasts varies from one person to another. These are different doses of Vyvanse. Doesn't show you the 10 milligrams. The way we do in our clinic usually is we start with a baby-sized dose of any of these medicines, regardless of how old the person is, and then gradually taper it up from there we're looking for the sweet spot between too little and too much. Here's something, just an example of, there's Vyvanse and then Adderall XR. 30 milligrams of a Vyvanse is equivalent roughly to about 10 milligrams of Adderall XR. And you can see the other equivalencies. And then the Adderall or XR and Focalin XR release only half of the capsule. It's at the face value at a time. And that's the example I gave before, 5 and 5 rather than straight 10 across the day. Common side effects: appetite down for lunch usually. Generally within a few weeks that gets better. Difficulty falling asleep can usually be fixed by just not taking it quite so early, not so close to bedtime, getting a little earlier. And if there's irritability, if it's happening throughout the day, we've got one problem. That means the dose is probably too high, or it's not a good medicine for the person. But if it's only happening when the medicine's wearing off, that's a completely different problem. And this is a very important point that a lot of prescribers do not take into account. And that is, this is the medicine kicking in. It does its thing. It takes a little while to kick in, does its thing for whatever the duration is for that particular medicine, and then it winds down. If during this time when the medicine's supposed to be working, the person is feeling wired, like they've had way too many cups of coffee and they're kind of jittery, and then that gets better when the medicine wears off, the dose is too high, or it's not a good medicine for them. Same thing if they get really irritable, where every little thing is pissing them off way more than it would normally, and then they get better when the medicine wears off later in the day. That's probably too high a dose, or one that's not a good medicine for them. Or the other thing is what I'm calling here too serious, or loss of sparkle. This is the sort of zombie reaction I was talking about a few minutes ago. During the time that the medicine's supposed to be working, if that's happening, probably the dose is too high, or it's not a good medicine. However, if these things are happening only during the time the medicine's supposed to work, and they get better when the medicine wears off, we know that the dose is too high, or it's not a good medicine for them. But if that's not happening during the day, for example, during the school day, and then it starts up these things, any one of these symptoms starts up late afternoon, early evening, that is a completely different problem. That's a rebound. And what it means is not that the dose is too high, because that you would have seen back here. It means it's dropping too fast and the person's crashing. And that usually is a pretty easy problem to fix. You give a small dose of the short-acting version of the medicine, and then you can bring that dose down at a more gradual rate. So this issue of rebound is something that really, if the person's having problems with the side effects, you always got to ask when, what time of day is it happening? They can usually be fixed with adding a smaller dose shortly before the rebound occurs, so the dose just tapers off more smoothly. Sometimes we need to use a short-acting in the afternoon because the long-acting medicines wear off too soon. And sometimes we also need to do, or instead need to do, a short-acting first thing in the morning with a long-acting because the long-acting takes too long because the person's got to start doing things earlier. But the main point here is higher doses are not always better. The dose and timing need to be carefully adjusted to each person, and there's a lot of variability in terms of how fast people absorb the medicine and how fast they excrete a particular medicine. And this is a study from the MTA study back when there weren't as many long-acting ones, but it was a very careful study of kids that started at age 7 to 9, and they were using short-acting medicine throughout the week. But the point here is look at these percentages. About a third of the kids responded best to 15 milligrams over the course of the day. There'd be 5 milligrams 3 times a day. Another third of them responded best to something in the range of 16 to 34 milligrams a day. Divide each of these by 3. And then there's another 38% who did much better on 35 up to 60 milligrams. And this is from a paper that was published back in 2001, but a lot of people don't have the message. The weight group, how much you weighed, whether you're anxious or not, or oppositional defiant disorder, had no significant effect on which of these would be the optimal level for the person. And the other thing that this is showing us here is again tied to the MTA study, is that 77% responded, these young kids responded to carefully titrated methylphenidate, and were on it, 88% were still on it for over a year later, but 61% needed dose adjustments within the first 13 months. And some of those, 62% were to increase the dose, and a third of them to decrease, and then 7% had to switch. And 90% responded well to either methylphenidate or to the amphetamine if the dosage adjustments were made as needed. So we've got empirical research on this. Now, I'm getting close to the time I need to stop, so I'm sorry that I've got too many slides here for the time that we allowed. The point here is that there are some advantages to the extended release formulations, but for some people, the short-acting works better. And some problems, these are just things that can be done with, if you got some irritability, you adjust the dose or maybe switch to a different medicine. Appetite down, you just have to, think about making some adjustments. And if the appetite is down for supper and you're having trouble with it, then try to get the dose in early in the morning. But as long as you get the person to eat a decent breakfast before they take the pill, or within the first half hour, they're usually going to be all right. Sleep time, these are all just considering some of the side effects, but these are all things that are usually quite workable. And there are non-stimulant medications, atomoxetine and guanfacine, that for some people work quite well. The guanfacine is more calming. It's not as strong for improving attention, but it's very good for a lot of kids who are too hyper and too restless and too anxious. Atomoxetine, usually we think of that as a third-line medication. For some people, this is the only one that's weight-based. The other ones are not. It works very well for a few people when nothing else will, but it's not as strong, and there are some other disadvantages for it in terms of getting adjusted to it. But my other point here would be pills don't fix everything, and that ADHD does result from impairment in brain chemistry, and the medication is the most effective, but the medicine's not going to be effective if it's not taken, and it's not going to fix everything. Parents can do a lot to help let the prescriber know about what problems you're seeing, what they are, and when they occur. The time of day makes a big difference in how long they continue. Is it he had a headache just the first 2 days he was on it, or is it something that persisted? And also report the benefits. And the other thing that's important is regards to what medicine you're taking. Don't assume that all the changes kids' behavior and the adults' behavior are due to medication. sometimes that's something that's due to something else. You may be coming down with a cold, for example. If it's not working, ask the prescriber if the dose might need to be increased or decreased. Ask if it's time to try a different medicine. Consider whether there's maybe something else besides ADHD going on, and consider anxiety or sleep problems or stress or a medical problem. And this is simply emphasizing that pills don't do everything. These are the books I've published, and right now I will finally stop for a few minutes to take a few questions.
Thank you, Dr. Brown. You did a great job of reinforcing the fact that response to medication is individual and is personal. I was really struck by that. The research that showed the number of children who needed a lower dose versus a higher dose versus a different dose was pretty compelling. How would you advise listeners to successfully work with their prescriber? I know it's a big problem for our attitude listeners who oftentimes have a hard time getting appointments, don't have enough time to work with, don't have someone who listens, who understands, who's willing to change doses. Do you have any advice for how they should go about putting into place what's clearly the real need for individual medication decisions?
Well, I think the first thing I want to say is that you need to understand that many prescribers who are not specialists in ADHD have had relatively little training in how to assess, treat ADHD, and how to use these medicines. The fact is that this is one of many different things that, for example, pediatricians need to learn about. And the average amount of time that most physicians have had in medical school and residency training is about 20 minutes. At least that's what I hear from them. There's some doctors are very good at it and have really done extra studies to get it, but not every physician is equally competent in dealing with this. But the thing that you can do to help them is write down what you notice. For example, if there's a symptom that you're having, for example, if a kid is getting crabby, or a kid is getting too wired or difficult, it's really important to know, is it happening in the morning, in the afternoon, or in the evening? It doesn't have to be down to the minute, but you need to see what chunk of the day is it happening. And you want to get account, for example, of if the kid's in school, what do the teachers have to say? Because there's some kids who are doing very well on a medicine at school, and then it all falls apart when they get home, because by that time the medicine's worn off and they're not getting a booster dose, which they might need. There are other kids who are not doing really well at school, but they're behaving much better on their medicine in the late afternoon or early evening. It's depending on how they react to what medicine they're getting and when it kicks in.
Okay. Yes, it's really interesting. Here's a question that I've never seen before. Is there any rationale for giving a patient both an amphetamine and a methylphenidate product?
Sometimes we'll do that. For example, if it may be that the methylphenidate is a little milder, generally milligram per milligram, than the amphetamines. And there are some people where we'll use an amphetamine during the day because it works better for them, and then we'll use a little bit of methylphenidate as a booster dose because they're less likely to have sleep difficulties with that.
Okay, that's interesting. Yeah. You mentioned that anxiety, the presence or absence of anxiety, didn't affect in the research the results of medication, but there are a lot of listeners asking questions about treating ADHD simultaneously with a person, either an adult or a child, who also has an anxiety disorder. Can you comment further on that?
Yeah, that's important. There was a review study that was published just a year or two ago where they looked at a large number of studies of people on stimulant medications to test the notion that a lot of people had of, if you've got somebody who's anxious and you put them on a stimulant, you're going to make them more anxious. And it turned out when they were looking at controlled studies, that's not true. The vast majority of people who are anxious when they're on a stimulant, their anxiety stays the same or might even get better. Okay. However, having said that, there are a few people where it will jack up their anxiety. And if that happens, you can usually see it fast. and you may be able to deal with by adjusting the dose of the medicine, reducing it. Or the other thing that we'll do often is add a second medicine, for usually like an SSRI, like sertraline or fluoxetine, to try and reduce the anxiety. But the thing is, the stimulants cannot be advertised to treat anything other than what's officially part of ADHD. That's what they're approved for. So they can't tell you this, but I can tell you that in our clinic and in the practice of many people that I work with and have collaborated with, many people find that if they're on a stimulant, particularly the longer acting ones, often that reduces the anxiety, and it also reduces depressive symptoms.
Okay, interesting. Right.
For some people, I have to add.
Yes, of course, depending. Lots of questions about medication breaks, and not just in children. There's some adults listening in who have been told by their practitioner that they should not take their medication on the weekend. In fact, one person who says, I don't want to do that because I'd like to be focused on the weekend as well. Do I have to?
If it's working for the person, there's no reason why they have to take a break. That advice is something which was back in the day when they thought that these medications caused kids to not grow as fast, or that they might stunt their growth. That's all been sort of clearly proven to be wrong.
Okay.
But what we do sometimes is, if you've got somebody who has persisting difficulty with appetite, where they just can't eat very much, and they're too skinny, and they need to eat more, then we'll often ask them to take a break on weekends and on school vacations to try to get some more food in them. Because it can diminish the appetite for some people. Usually that gets better within a few weeks, but it doesn't always. But otherwise, there's no reason why. If it, my feeling is, if it helps and it's not making any trouble for you, it'd be sort of like, I wear eyeglasses, and there's some people who only need their eyeglasses when they're reading, or only when they're driving, and there are other people like me who need them for everything I do.
Okay,
and
right.
Those vary.
A question sort of along, just to continue along what you were just talking about, and that is from a psychologist who asks about his clients who are also on antidepressants, SSRIs. Is there any concern about stimulant interaction with
No. Actually, I published a paper about that. But the fact is that you're working on two different chemical systems.
Okay.
And so they sometimes work well together, those two medicines. We use them a lot for anxiety disorders and for OCD and for depression. But you don't start two things at one time. You start one thing, see how it works, get the adjustments made, and then you try a second thing if you need it.
Can you talk somewhat about making the decision to change a medication? That seems to be difficult for many people. Some of them say their physicians don't like changing medications. Others say they're not sure whether they should change medications. How does one go about determining that it's time to try something completely new?
Well, for one thing, if you're getting some side effects and you're early on in the process of checking out the medicine, and moving it up gradually to adjust to find a sweet spot, it does not make sense to change the medicine unless you're getting some side effects that are really uncomfortable and making a lot of trouble, and they persist. Because a lot of side effects go away within a few days or a week. So the first thing you have to ask is, how long is the problem going on? And the other question is it working? Is it doing anything good? Are there benefits to the medicine and there's some side effects, or is it that there are no benefits and we're having side effects? And it's different if you've got small potatoes side effects. Often those clear after a week or two or three, and they can often be adjusted by adjusting the medicine, or sometimes it has to be reduced. Sometimes the dose is too high. Or sometimes you get a good response to a medicine as you're moving it up one notch at a time, and then it fades. For example, when you're first starting a medicine, it's not unusual to have the person say, oh, it was wonderful. I really felt much better able to focus. And then the next day or two, it didn't work. Usually what that means is you're almost at the right dose, but not yet quite. So you tweak it up just a little bit more.
Okay. And then another question that I see here from a number of people relates to a medication that they've been taking for 2 or 3 years effectively that seems to no longer work. Have you seen that in your practice, and what does that indicate?
You see that with all kinds of medicines. You see it sometimes with allergy medicines. You'll see it also with antidepressants. And sometimes it's simply a matter of you need to take the dose up a little bit in order to see if that'll work better.
Okay.
However, there's sometimes when you can take it up and it still doesn't work, and usually at that point you need to change medicines.
Okay, so that's an indication of the change.
Yeah, and sometimes a medicine just poops out, and then you can switch over to something else. If it works well, stay with it. And if after a while, if it's not working well and you've adjusted the doses, then you might be able to go back to the other one after the original one if you take a break on it for a matter of a month or two.
Okay, that's interesting. Along those lines, there's a parent of a child who developed hallucinations with Concerta. And as a result, they stopped the Concerta, went to a different medication. She's wondering, and apparently Concerta was by far the most effective for this child in terms of managing ADHD. She's wondering, and this question has come up with tics as well, whether it's ever possible to reintroduce a medication at a lower dose down the road.
You can, but the problem is when you're doing it with a medicine like Concerta, where it's a time release, often there's going to be, particularly with Concerta, there's a point where you get a high peak, and then it gradually comes down. And first of all, it's very unusual to have somebody have hallucinations unless they got some particular vulnerability. It's in the prescribing information of a stimulant can do it, but what that usually means is if you're really overdosing with it. But there are a few people whose bodies are exquisitely sensitive to that kind of thing, and basically you want to be sure you're not peaking out with a dose that's too high that's going to jack that up.
Okay.
And so for that, I think one would probably want to think carefully about, first of all, is there any other indication that there's a problem even when the person's not on stimulants? That might need to be addressed, because sometimes hallucinations are coming for other reasons.
Right.
But if it happened just in response to the stimulant, the first thing you do is get them off that stimulant, and then you can cautiously try another stimulant and watch your dosing so it doesn't go too high too fast.
Okay. A question about the long-term effect of medication. For example, does the brain build up a tolerance? Can there be permanent adverse effects to the synapses?
There's no.
Can you develop a resistance over time?
There's no adverse effects that are persistent. The thing that people worry about is, it's going to cause heart damage, or is it going to cause brain damage over the long haul? And there are quite a few studies that have been run on this. That large number of studies I showed you includes some studies that are looking at longer term effects. And there's not any evidence that, for example, you're subject to having cardiovascular problems as a result of taking the medicines. Those things are pretty well established, even for adults. But that's not to say a person can't have a problem. It's a matter of, does having the medicine increase your rate above what the rate would be for somebody else who was not taking medicine? Because that's the test you have to ask.
Okay.
And does a person develop a tolerance? Well, sometimes, that's the sort of poop out problem I was talking about before, where it works for a long time, and then sometimes it just doesn't do what it used to be doing, and then you have to adjust the dose. If that doesn't do it, you got to look for another medicine. Okay.
A series of questions about rebound. I guess this is rebound. One person says, I take my medication at 7 a.m., but then I become very anxious around 11 or 12 p.m. Another person says that her...
excuse me, on that question, was it 12 p.m.?
Yes.
So it's just a few hours later?
Between 7 a.m. and 12 p.m. So I guess that would be 6 hours.
But about a 5-6 hour thing.
Yeah.
It's likely, if it's a long-acting medicine, it may be that the changeover is just pushing the level up too much for the person. And they might want to consider changing to another one that doesn't have the same rapidly ascending curve. So in other words, if they're on an Adderall XR or a Concerta, they might want to try a Vyvanse, which has a flatter curve.
Okay, something that is smooths out.
Yeah, exactly.
And this whole question of the delivery system being obviously very significant. Another parent says, how do I approach my son's physician to ask him to optimize stimulant medication during the afternoon and evening hours so that he can function in society rather than having to decline evening activities? So it sounds like I'm calling that a rebound, but I'm not sure, but that's the description.
The rebound is when things get worse as the medicine wears
Okay.
off. But there's some people where it's just that the stuff wears off and you don't have the benefits. For example, if you've got an adolescent who's driving and they do much better focusing when they've got medicine in them, it's a mistake to let them drive without medicine in them.
Right.
Or there are a lot of kids who find that they can focus very well on sports, even though they've got bad ADHD, when they're doing the sport. And there are others where they can play well, but they can't keep their head in the game. And so they may need coverage to be able to the athletes I see go about 50-50. About half of the athletes I see, I'm talking now about high school, both little young kids and also high school and college athletes, about half of them find that they do better in their sport if they've got the medicine active at the time they're playing. And about half of them feel like they don't like having it in them during their sport because it makes them think too much. And there's that moment of hesitation at a time when they need to be able to just move forward. So those things vary, but you want to fine tune in terms of tasks, what it is the person has to do. And for example, there's some parents who, for a variety of reasons, the kid doesn't want to take the medicine on weekends, or they've been on a long acting during the day and they want to, during the weekend, they'll just give them a short acting just to get homework done. Or then again, they might want, if they've got to go to some family event that the kid is going to be bored out of his mind and hyper on, they might want to give the medicine for that particular event. And those are the times when short acting boosters can be helpful.
Okay, that's great. Thank you. We are regretfully out of time. I want to thank all of you for listening and thank Dr. Brown, especially for this level of knowledge is so helpful. I can't tell you. And to invite all of you to the next two webinars. Next Tuesday, Building Executive Function Skills in Your Child with ADHD. I think it was Sharon Saline. She's got some great practical tips. And then the final of our two-part series on medication with Lori Dupar on August 1st on delivery systems, specifically in ADHD medication. So thank you all. And if you really appreciate Attitude, we encourage you to subscribe to the magazine. I think you'll enjoy having a print copy coming in your mailbox every day. And to check out Dr. Brown's wonderful books. They really are clear, understandable, and as he is always, and super helpful. So thanks, everyone. Have a great rest of the week this summer.